So basically what is PNH? Manufacturing defect in the factory. Clonal stem cell defect it is called as. That too not at birth. Acquired clonal cell stem cell defect is the problem of PNH. Basically bone marrow mein stem cells. Stem cells are producing RBCs. When RBC is manufactured in the bone marrow, it has a membrane. On the membrane there are some surface proteins, CD markers, HLA antigens, so many things. It will put like crown of England is being manufactured and releases the RBC. At that level, due to a genetic defect, there is a problem in the production of one of the cell receptors that lead to increased tendency of the RBCs to be broken down by the complement in the blood after they release from the bone marrow. Hence, what is the buzzword you need to know about PNH? PNH is a acquired clonal stem cell disorder where the RBCs have an abnormal sensitivity to be broken down by the merciless complement which will be slaughtering the RBC once it is released from the bone marrow. What is the problem? Why that problem? There is a gene for PIC-A that is called as phosphatidylinositol class A protein. So the gene for this PIC-A will lead to deficiency of glycosylphosphatidylinositol anchor, which basically anchors the cellular membrane proteins. This is the main defect, right? So then one more important thing, the CD55 and the CD59, which are the complement regulating proteins, they are deficient in case of the people who are having paroxysmal nocturnal hemoglobinuria. So doctor, this is what is this stem cell is deficient in? GPI deficient it is, that is glycosylphosphatidylinositol anchor protein deficient stem cells will be there in case of the PNH. So what is the pathophysiology? If this glycosylphosphatidylinositol anchor for the cell membrane proteins is missing, a RBC which is missing that, when it goes into this merciless cruel world of plasma, complement will be waiting to kill it. If this is present, that is glycosylphosphatidylinositol anchor for cellular membrane protein is present, it acts like a protective factor from a complement mediated lysis. But our RBC does not have it. It is like a student who did not study general medicine and going to MD exam. He will be slaughtered, and fundamental aspects of the concept, ultimately if it is a negative marking containing exam, you may get the highest negative score. So that is what happens to the RBC. So in these review classes our intention is what? That acquired clonal stem cell disorder of not having had read all these concepts, we wanted to review, equip you fully, so no complement can destroy you when you go to the day after tomorrow's AIIMS exam. So that is my job. Now doctor, what are the important clinical findings? Episodic hematuria, hemoglobinuria, not hematuria, hemoglobinuria. When the RBC is broken down by the complement, where will it break it? In the blood vessel or in the spleen? Intravascular or extravascular? Intravascularly it will break it. So when the RBC is broken, it releases the hemoglobin which will cause hemosiderin. Hemosiderin will enter into the crosses the glomerular basement membrane and appear as hemosideриnuria. Hence there is a reddish brown urine is what need to be remembered. But when will you find it? In the first morning urine, you find the presence of hemoglobinuria. Hence it is called paroxysmal nocturnal. Night time all this killing job is happening, leading to the development of hemoglobinuria. Obviously, we will get in mind a doubt. Why only night? That it got that animal feeling to slaughter the RBC. Why it is vulnerable in a dark lane of the plasma when it is walking in the night only? In the night what happens? Except medical students, entire world sleeps. So when we sleep, what happens to our respiratory rate, doctor? Decreases. The decreased respiratory rate will lead to relative acidosis of the plasma. Only when that acidic environment is there, like old movies may they show, no? When they show a villain chasing the heroine, suddenly red lights will come. Nowadays they are not showing any of those things. Then they will show a peculiar face of the villain, and then he will chase the heroine. Then of course hero comes and fights, that is a different thing. So doctor, RBC also when it is going in the night, when the guy is sleeping, when the acidosis is there, that acidic pH milieu is an optimal milieu for a complement mediated destruction of the RBCs. So there is a reason nocturnal hemoglobinuria, except in medical students where it will be morning time hemoglobin, because that is the time they sleep and acidosis will occur if they have PNH. Then because of the hemoglobinuria there is an anemia. But one peculiar thing about PNH is they have a thrombotic tendency. Paroxysmal nocturnal hemoglobinuria guys, especially mesenteric vasculature, hepatic vein thrombosis, Budd-Chiari syndrome can be a presentation of PNH. Central sinus venous thrombosis in the brain leading to severe headache in a guy who is having everyday morning reddish brown urine means what will you think? PNH. Then there can be a skin thrombosis of the vessels leading to the development of painful nodules. Patient has gone to 10 dermatologists and ultimately come to you. Right? So, skin thrombosis. And what is the main reason, doctor, for all this hypercoagulopathy? Who is causing that fundamentally? In case of PNH, what is the central theme of the pathophysiology? Complement mediated hyperactivity. That complement, what it will do is, it will go and kick platelet. Platelet is like a pregnant atom bomb of chemical mediators. Platelet releases a lot of prothrombotic factors which are there in the platelets. The moment this complement kicks in, platelet vomits all those prothrombotic factors, and that lead to development of a thrombotic tendency. So once more, thrombotic tendency is explained by the complement mediated platelet activation is what you need to remember. So what are the triad of clinical features of the PNH, doctor, which you are not going to basically remember? Hemoglobinuria. What is the meaning of this representation? Blood is red, urine is okay, but the morning sample of the urine is brown. As the day passes, it will once more normalize. If you take serial urine samples from morning towards evening, presence of hepatic vein thrombosis, Budd-Chiari syndrome, and one of the important problem of the PNH is it is a clonal stem cell defect. Since the stem cells themselves have a defect, they are vulnerable to get destroyed, and that can lead to aplastic anemia, is one of the complications of PNH. Now comes a very important story I will tell you. We used to have a very interesting patient, Ram Babu. He is from Srikakulam. the first case of PNH I have seen in the hematology ward. To get seat in MD, you will read lot about PNH, but first time when you see PNH, there is not much of dramatic thing. Of course, one dramatic thing is patient had a butt cherry, had a severe abdominal pain, acutely diagnosed. Later on, all other proofs, flow cytometry, everything proved it as PNH. He used to come regularly for follow-up. In PNH, if you find anemia, what is that anemia? Because of intravascular hemolysis. Any hemolysis, what will you see in the complete blood picture? Any hemolysis will lead to, remember, golden rule, if the anemia is due to hemolysis and hemolytic anemia, bone marrow will try to compensate that hemolysis happening and produce brisk reticulocytosis. 8%, 9%, 10% reticulocytosis is called brisk reticulocytosis, right? So regularly patient used to come for follow-up who is a diagnosed case of PNH, and his reti count used to be 8%, 7% with anemia. Suddenly one of the follow-up visits, he came with anemia but reti count less than 1%. Why will it happen? PNH at one point of time can transform into aplastic anemia. At that point of time, reti count will be, because bone marrow is not there to compensate anymore for the anemia. So less than 1% reti count. So a PNH patient with anemia with a high reti count is because of the expected finding due to the intravascular hemolysis. A PNH patient with anemia with a low reti count less than 1% means which complication it develop? Aplastic anemia. That is what you need to ultimately remember, doctor. So this is in a magnified view. Normally the superior sagittal sinus must be visible when you pass contrast through and through, but there are filling defects, you are not able to see. That is how you recognize the presence of the superior sagittal venous thrombosis. So what is this appearance in Butt-Chiari syndrome called as, doctor? It is called the spider web appearance. When there is a hepatic vein thrombosis, out of all the lobes of the liver, caudate lobe has a special circulation. What is that? It is directly related to the IVC, right? So that is the reason there will be lot of collaterals developing. So many collaterals, like it looks like a spider web. So spider web appearance of the Butt-Chiari syndrome due to excessive collaterals is what you are able to see. So the CD55 is very, very important because we have seen deficiency of CD55 will increase the complement mediated lysis of the RBCs is what you need to remember. So the various CD markers which are basically deficient in the case of the PNH. So what are the various things to which PNH can progress, doctor? Ultimately aplastic anemia, myelodysplasia, AML can develop in a patient of PNH. And when will you suspect PNH? If a patient has a hemolytic anemia or pancytopenia, but it is a confusing case because he is also having thrombotic tendency, then you need to suspect possibility of PNH. So what do you find in PNH? Generally anemia with reticulocytosis is a normal finding, general finding, and because bone marrow is trying to compensate, unless aplastic anemia develop, bone marrow compensates. You may find abnormally shaped RBCs, macroovelocytes can be found. Not only in this, any condition where bone marrow is trying to over proliferate, macroovelocytes will be found. Since it is an intravascular hemolysis in PNH, what do you find? Hemosideриnuria. Then LDH classically is elevated because of the intravascular hemolysis of the RBCs. LDH become elevated. Then patient will have iron deficiency because hemosideриnuria is making iron lost in the urine, and if the aplastic anemia develop, then even WBC and platelet count also become diminished. Now comes the favorite MCQ of the examiner. If I ask a question, best screening test in a suspected case of the PNH, what it is? Don't give any innocent answers like CBP or hemosideриnuria, sucrose hemolysis test. Examiner will know that you have a clonal stem cell defect and prevent you from getting joining MD. What should be your confident answer? Flow cytometry. What will you show in that? Deficiency of CD59 and CD55 on the RBCs is what you are going to demonstrate when you do the flow cytometry is what need to be remembered. If you do bone marrow, what do you expect? Either erythroid hyperplasia will be there if the aplastic anemia has not yet developed. If aplastic anemia developed, then there is a generalized hypoplasia. Either of the two are possible. So flow cytometry is considered to be the best screening test where CD59 presence is basically tested. So how will you treat, doctor, the PNH? Prednisolone has a peculiar effect of decreasing the amount of the hemolysis. In fact, some patients on the PNH can be managed by alternate day steroids. Then, in very severe case, if you have money in the pocket or a supporting father-in-law, what will you do? Allogenic bone marrow transplantation. Then, anti-complement C5 antibody, eculizumab. Hematology means some QQQ ABBB. You have to remember. Monoclonal antibodies, doctor. One big list you have to prepare before going to exam. Eculizumab, anti-complement C5 antibody, will reduce the hemolysis and the transfusion requirements is what you need to ultimately remember. That is the story, doctor, called as PNH.